Hello, everybody. Welcome to today's Merit CRO Oncology webinar. Today, we will be discussing RANO 2.0 in oncology imaging endpoints. Please note we are recording this webinar so that it can be added to both our website and YouTube channel for replay. All attendees will receive a follow-up email with a link to this recording, which we welcome you to share with fellow colleagues and industry connections as you see fit. All participants will be muted during the presentation. However, we will devote time to questions and answers at the end. We invite and encourage you to submit questions at any time throughout today's presentation via the Zoom Q&A functionality. Our presenters will address as many questions as time permits, and all remaining questions will be answered directly via email following the webinar. My name is Chris Sylvia, and I specialize in connecting East Coast of the United States and European clinical sponsors with our central review imaging teams for more effective clinical trials. With experience working alongside CROs, sponsors, and research teams, I play a key role in ensuring seamless imaging workflows that support high-quality oncology research. And I'm pleased to be joined by our presenter today, Dr. Jean Kim. Dr. Kim is an Associate Director of Medical Affairs in the Oncology Division at Merit. He provides subject matter expertise and helps design and configure Merit's Excelsior platform to accommodate various reading paradigms. Dr. Kim has experience in evidence-based patient care and academic research, a background in pharmacy, and 6 years supporting clinical trials. Dr. Kim has a special interest in oncology clinical research, cancer pharmacology, imaging biomarkers, and various tumor research criteria. He helps to increase the efficiency and accuracy of clinical data collection for imaging endpoints. Now I'll hand it over to Dr. Kim to cover our agenda for today.
Thank you very much for introduction, Chris. All right, and thank you everyone to join our webinar today. We'll be going over a lot of the updates that the RANO 2.0 has been done after the publications or on 2023. So we'll go over the brief history of the neuro-oncology response criteria development from McDonald's criteria up to today's RANO 2.0. And the next, our agenda will be an overview and what is the purpose of the RANO 2.0 updates. And then what are the major changes and the differences, and what are the trial considerations incorporating the RANO 2.0 as compared to the RANO HGG and LGG, the traditional criteria. And then lastly, we got some 2.0 response examples and some of the special considerations that the publication specifies by the last couple of minutes of who we are as a Merit and what we do for just the 1 or 2 minutes there. All right. So just an introduction for the neuro-oncology response criteria. There has been many of the developments and adaptations to the different type of therapies or subpopulations, such as pediatrics, immunotherapy, or high-grade, low-grade, and brain metastasis. There are very much of a work done from the RANO working group as a criteria that is well tailored into each type of the specific scenarios. And I just wanted to give you a snapshot. There are various response criteria to be considered for specific studies that you are designing and working on. And a brief history of the response criteria of the neuro-oncology work by the RANO working group is actually starting back in the McDonald's criteria in 1990s, the very initial guidance on how the CNS tumor response criteria can be assessed based upon a bidimensional measurement of the lesions. Followed by the early 2010 and 11, we had the high-grade and low-grade glioma. And this is an update from a guidance from the McDonald's criteria, and have some improvement and discussion on limitations from the McDonald criteria to how to better assess these glioma types, including the flare sequences and a low grade for the non-enhancing portions. Later on 2015, we also had publications in iRANO and RANO BM published by the RANO working group that is specifically built for immunotherapy considerations and brain metastasis, which are supposed to be used for solid tumors that can invade a brain which can be used together with the RECIST 1.1 with the separate compartment for the CNS portion that is the brain metastasis. All right, and then in 2017, the modified RANO that really defines the preliminary PD and pseudoprogression in the better algorithm has been published for the consideration for a post-treatment related changes that is more or less described as a pseudoprogressions. RANO is for pediatric response criteria in the 2020. And finally, we're at the 23-24, where we had the RANO 2.0, which incorporates various different scenarios into the one response criteria. And we can discuss a little more in details of the RANO 2.0 here. So RANO 2.0 updates, and the main purpose I just wanted to point out over here is basically a further standardizations after multiple publications and an improvement that the existing RANO criteria for all grade glioma assessment can be done under the single response criteria that actually specifies the different types of criteria guidance. And it also aligns with the 2021 WHO CNS tumor classifications, which now incorporates more of a molecular profiling rather than just solely based upon a histology. So they're incorporating these as well as the challenges of pseudoprogressions that causes some concerns for premature discontinuations for some subjects potentially could have been beneficial by those investigational drugs. So these pseudoprogression challenges and addressing how to deal with also helps to make sure premature discontinuation can be avoided using these. Also incorporating other various response criteria such as an mRANO, iRANO, HGG, and LGGG. LGG also is incorporated into the RANO 2.0 and also is supposed to be used regardless of the treatment modalities. Slide here. So what are the major differences in RANO 2.0 compared to the high grade and the low grade versions? The major update is that the classification of the glioma type for which criteria to be used based upon the grade now is more specified as radiographic features. Also, they have a specific updates in the glioblastoma assessment. Baseline imaging designation is also a big change. And some target lesion, non-target, and new lesion management has been slightly updated for the better algorithm for confirmation of PD and the pseudoprogression considerations. And then also the pseudoprogression window and definition of true progressive disease based upon these target, non-target, and new lesion management. Okay, before we jump into the RANO 2.0 changes and updates, I just wanted to review really quickly some basic information about the imaging endpoints for CNS tumors, which are either in a newly diagnosed glioma settings or the recurrent glioma settings. So often newly diagnosed glioma settings, the progression-free survival is a imaging endpoint to be used. And this is often a patient that has no measurable disease or lesions at the baseline skin, which they go through a surgical resection and followed by the chemoradiations, and usually the patients who's entering into the newly diagnosed glioma settings into the study will not have a measurable lesions at the baseline. And in this case, the best response for these subjects that can reach per RANO or RANO 2.0 will be a stable disease, not partial response or complete response. So in this case, the progression-free survival would be an imaging endpoint to be used for newly diagnosed settings. For recurrent glioma settings, either progression-free survival or the objective response rate can be considered based upon the eligibility criteria, and that is a more scenario where patient has newly diagnosis being on a treatment, and there is a new measurable lesions that's appearing or progressing that requires a leaving out of the another trial or the current standard of care and being considered for a new treatment of the recurrent glioma settings in the clinical trials. And usually these patients will have a measurable lesions to be started off at the baseline that can accurately assess the responses based upon their sum of the product of diameter and a percent changes to be able to derive the response rate. So first, diving into that RANO 2.0 updates, classification of the criteria for the glioma. In the HG and LGG, based upon a WHO grade 1, 2, 3, and 4, considering the 2 and a 1 will be the low grade, and 3 and 4 being a high grade glioma, including the glioblastoma that falls under the HGG criteria. Now the RANO 2.0 classifications will be more or less important feature to consider. Which criteria to be used is actually a radiographic enhancement feature is the CNS tumor trying to be assessed in a certain clinical trial, enhancing dominant tumor or non-enhancing dominant, or are they predominantly a mixed of enhancing and non-enhancing criteria? So these are the three main criteria that is specified in RANO 2.0, and this is actually a consideration of that tumor classification update, just not only based upon histology, but also these molecular profiles and what these CNS tumors have a better or worse prognosis based upon those molecular profiles, so that these criteria should be three different types that's specified in the 2.0. Important thing for these is that these subtypes and which criteria to be used should be a defined criteria and determined a priori before the study starts per protocol and a charter. So this is the one important considerations, that this is more of a predefined criteria, that which patients goes into which criteria for their assessment while the independent review of the radiology occurs for this study. And also updates on the glioblastoma assessment is that in the RANO HGG, there were also recommendations to assess the T2 or the flare sequences to assess the non-enhancing portions. And a lot of researchers in the RANO working groups are realizing the non-enhancing lesions are actually not directly correlated to the overall survival, even in the settings of the anti-VEGF, and could also complicate the assessment incorporating. So a glioblastoma is now recommended. It will be assessed based upon a T1 post-contrast enhancing images or target non-targeted new lesions, and then T2 flare sequences are not needed to be assessed. And also big updates on the RANO 2.0 in terms of pseudoprogression, and a confirmation of the PD workflow has been assessed. So before going into this slide, just wanted to touch base on what is the pseudoprogression in neuro-oncology or RANO criteria. So this is more of a treatment-related imaging changes that mimics the true tumor progression. So that is named how it's named, the pseudoprogression, not a true progression of the disease, but it mimics that enhancement and does not really reflect the actual worsening of the disease in the pseudoprogression setting. Usually associated with the increased contrast enhancement in a T1 contrast enhancement images. And per RANO 2.0, these are something seen in the enhancement, but not in the non-enhancing portion. So it is recommended to consider the pseudoprogression outcome only for the enhancing lesion criteria. So confirmation of PD based upon these progression consideration. So just when does these pseudoprogression consideration is needed? So it would be a IDH wild type glioblastoma, have a very typical within the 12-week of the chemoradiation end date, where the pseudoprogression is very common. So this will be a confirmation of PD to ensure is it a true progression or pseudoprogression should be confirmed and should be mandatory for the first 12 weeks of the this patient populations. And also in any novel agents that is known for a high incidence of the pseudoprogressions should can be an optional confirmation of the PD so that the mandatory confirmation of PD can be applied for as a workflow of the independent review throughout the course of the treatment in that case. And generally, these confirmation of PD visits should at least be 4 weeks or more interval to make sure that the changes are well seen, just to make sure is this the true progression or a pseudo progression. And this is just the one classic example from a one of the reference literature here showing the pre-radiotherapy of the enhancements, followed by the 1 week after the radiotherapy was completed, showing a enhancement in the lesions, followed by a resolution of those pseudoprogression in a 3 month after the post RT, which is an example of the pseudoprogression in this case that is induced by a chemoradiation therapy. And then also RANO 2.0 updates on a baseline MRI designation is actually on another update. So MRI imaging for the newly diagnosed settings. It used to be a post-operative MRI within the 48 hours, was the baseline scan in RANO HGG. In the RANO 2.0, now recommends that post-radiotherapy MRI around after the 4 weeks should be a baseline scans, which can have about a week window plus n-7 from the 4 weeks, so 21 to the 35 days from the end of the chemoradiation. So which should be in this case of the newly diagnosed setting where surgery has occurred within the 48 hours. The post-operative MRI can be captured to monitor any post-surgery complications or progressions at this point, and then going through these radiotherapy and have a post-radiotherapy MRI to be captured, which should be used for the baseline, and then can be followed up with the further MRI in future time points. Any gliomas that does not usually go through the radiotherapy, such as low grade in certain settings, still the post-operative MRI is not recommended as a baseline. But the RANO 2.0 recommends the protocol-defined pre-treatment scan should be used as a baseline with the consideration of post-operative changes to be resolved after the surgical resection, but also within the 14 days of the initial treatment to be started. And for recurrent settings, MRI imaging for the treatment as a best practice closer to the treatment for the accurate assessment and not further than 14 days before the intervention actually starts. Okay. Target lesion management in RANO 2.0, there are some updates and some of the measurability of the requirements still stays the same. Bidimensionally, greater than 10 millimeters in both axes should be a requirement and visible in 2 or more slices. And the selection of the target lesions can be up to 3 lesions per patient. And this should be based upon a size and a reproducibility. And for any multifocal gliomas, rapidly growing recent lesions can be also have a priority regardless of the size in that case, measured in a plane of the measurement that the lesion is on the largest extent shown in the scan. In case where you are assessing a mixed contrast enhancing and non-enhancing tumor altogether in a one patient, can be up to 2 enhancing and 2 non-enhancing lesions as a target, which would be a total of the 4. And then any enhancing lesion that is located within the non-enhancing lesions also can be measured in this case. And for non-target and a new lesion management, particularly in the case of the enhancing lesions where non-measurable lesions and a new lesion appearance should be considered in this way. So any non-measurable lesions at the initially should be just be monitored for until their size has substantially increased, which non-measurable lesion turning into a measurable size, increasing by 5 or more in both axes. These progressing lesions should be calculated with the product of the diameter and then added to the target enhancing SPD to be able to calculate the progression in this case. Also, the new lesion enhancing tumors have a updates here that new lesions should not necessarily just be called as a progressive disease immediately, but rather any new lesion should be monitored and the new measurable lesion should be added to a target enhancing SPD incorporated for calculation of the progression. So that's another updates over here. So incorporating these confirmation of PD and some lesion management getting in together, computation of the progression based upon SPD for these patients can be done in this way. So for instance, total enhancing lesion SPD will be a target enhancing SPD added by non-target enhancing that are progressing. Then any new measure of enhancing SPD should be added to be to calculate the progression of the disease. So this 25 increase in total enhancing SPD, which should be a sum of all three lesion categories, is calculated. And if it's an increase by 25% or more, should be progressive disease. And especially in the setting that where confirmation of the PD is required, at time point N, which is one of the follow-up time point, preliminary PD can be assigned in the case where this total SPD increases 25% or more from the nadir. And this would be a time point where you would assess whether it's the patient actually going into a truly confirmed progressive disease, or was it actually a pseudo-progression? And in the confirmation PD workflow settings, confirmed PD can be reported in case there is another 25 or more increase in total enhancing SPD in comparison to the preliminary PD time point N. If that actually occurs, that would be a confirmed PD. And the patient can be labeled as a stable disease for their overall outcome in the case where confirmed PD criteria has not been met. And in this case, the stable disease will be labeled. And the time point in preliminary PD is updated to the confirmed pseudo progression as their time point outcome in this case. And then further time point after the pseudo progression has been determined, the confirmed PD is reported based upon a 25% or more increase from the nadir after the confirmed progression. So any sum of the product of the diameter that is as small as after the time point N should be considered to confirm a PD in this case after the pseudo progression has been determined. So this is one thing I just wanted to sort of emphasize that the reference point actually changes here for the confirmation, confirmed PD. And then this time point N+2 and on, the response computation is based upon a baseline. So this new nadir time point only serves for the confirmed PD reporting, but the patient ever responses back to the PR or better, this one will be calculated based upon a baseline. So this will be some easy examples based upon a prior slide, which the patient has just a non-target enhancing non-measurable lesions that are stable throughout the time point, but the target enhancing lesions are changing, being followed in baseline through the follow-up time point 4, which patients will start with the 10/11 in this example, which calculates a total SPD of the 110. And the next time point, we have a SPD change of the 121, which would be 10% increase from the baseline. This does not meet the progression nor responses, which can be reported as a stable disease based upon a criteria. And then at the follow-up 2, we're observing a 65% increase from the baseline, which is also nadir in this case before actual progression, the pseudo progression has been confirmed at all. This will be preliminary PD at the time of the follow-up 2, which is followed by the follow-up 3, where they showed a 34% decrease from the preliminary PD time point, which is now a 25% increase from this time point, is reported in SD. And as soon as the follow-up 3 SD is actually labeled, these time point preliminary PD is also updated to the confirmed pseudo progression when the follow-up 3 has been confirmed to be not a actual progression. And then follow-up 4, a lesion size changes into 169 millimeter square, which is a 40% increase from the nadir after the pseudo progression, which is referring to a follow-up 3. So this is now a pseudo progression time point. So the actual confirmed time point after the follow-up 2 will be referring to any nadir after the pseudo progression has confirmed, in this case, 120 millimeters, and 25% increase from this time point will be meeting the criteria for the confirmed PD. So in this case, after the pseudo progression has confirmed, the patient does not go back to preliminary PD status, but computation of the PD will be directly based upon a nadir after the pseudo progression for the 25% increase with as a condition. And also a updates on the neuroradiologist guide for the RANO 2.0 publications also mentions a couple other considerations for the measurement, which I wanted to point out as our last couple slides here. Target lesion measurement, there could be some cases that some measurable lesions can be connected by the non-measurable. In this case, it is allowed to measure two separate component of the measurable lesions as a two separate target lesions to be followed. Also, entire bidimensional measurement diameter should be really like within the lesions, but not outside the lesions. So there is one good example in the publication where they mention correct version and incorrect versions of these measurements. And then also non-measurable lesions for certain cases are rim enhancements around the surgical cavities, or any cystic component should not be considered as a target, but rather a non-target. And in this example where the measurable, if the enhancing component around the cavity, the nodule meets the measurement criteria, then this lesion can be considered as a target. So where this example features that the correct measurement in the case where the nodules are measurable, but the cavities are not considered as measurable, so that this is a correct recommended measurement type as an example here. And then also the longitudinal lesion assessment in the case of the mixed enhancing and non-enhancing tumors. So when the third type of the response criteria has been used for the RANO 2.0, which is referred to as the mixed enhancing, non-enhancing response criteria. It is recommended that the enhancing compartment of the lesions and non-enhancing should be followed into two separate compartments. And the rules for deriving the overall time point would be one or two groups, either one or two groups meeting that PD or the progressive disease will result in an overall time point for the subject as a progressive disease. So basically following a conservative fate of actually one or the other is a PD means the patient is progressing in this case. But in the case where there are stable disease in the one side, but the other compartment actually shows a response, in this case, the overall time point outcome can be updated to follow the better response. And for example, enhancing lesion compartment reporting a PR, but the non-enhancing is stable, the overall time point can be reported as a PR following the enhancing compartment. And then also pseudoprogression is not generally needed to be considered in the case of the mixed tumor, where the enhancing and non-enhancing are both dominantly shown in the patient's image, but the preliminary PD can be still considered with the pseudoprogression just for the enhancing portion, and this should be specified as well in the part protocol in a charter so that um, everything is defined before the study starts for the consistency and the accuracy of the trial operation. So that is my last slide for our presentation today. And I just wanted to show a couple references here, which are the RANO 2.0 and a newly updated in 2024 from the Neuroradiologist Guide that has a couple more clarifications that can be very useful for considering how the RANO 2.0 can be applied. And thank you very much for everyone, and I'll pass this presentation back to Chris.
Right. Thank you, Dr. Kim. So you may know Merit from our many years of managing clinical trials in ophthalmology. We've served biotech and pharmaceutical companies, their clinical endpoint analysis for over 10 years. And we do that with a team of medical professionals and seasoned operational support staff. Merit is based out of Madison, Wisconsin in the US, but our company has a global reach. We have team members in reading centers all around the globe, so it makes it possible to support sites and sponsors from a variety of locations. And our impactful approach is a focus on three key areas, that being our software system, Excelsior. Excelsior can handle all aspects of imaging core lab in one system. So from acquiring images from a study site to performing independent reads, transferring data to a sponsor, Excelsior can manage and track images every step of the way. Second key area, Merit has a large network of over 300 radiologists and oncologists to help support our studies in a variety of therapeutic areas. And then the third being that Merit, we value a partner approach. So we work closely with our sponsors and sites to build trust, partnership, and long-term relationships. Merit is more than an imaging service provider. We are positioned to be an extension of your study team, and we offer support to our partners in a variety of therapeutic areas, including oncology and respiratory. So on the right-hand side, you can see that we serve as a trusted endpoint partner through four key aspects. So we leverage cutting-edge technology to streamline imaging workflows, ensuring efficiency and precision in clinical operations. And then you'll also see that our team comprises highly experienced board-certified radiologists and oncologists with extensive expertise in diverse clinical trials, and that's across various medical indications. We're supported by a dedicated team of project managers, imaging specialists, QA staff, and data managers, and we tailor our services to meet your study's unique requirements. And we also adhere to rigorous quality assurance protocols, and we ensure standardized and expertly managed clinical trials, delivering actionable insights and timely results. All right. Our robust QA management and data privacy are upheld by four cornerstones, those being quality management, which is certified by ISO, also data security, ensured by SSL, SHA-2 encryption, and also ISO certification. We have reliability with 99.9% uptime and geodispersed data backup, and we adhere to strict privacy standards, including GDP, Data Privacy Framework, and HGRAC. Merit will be attending several key oncology conferences in the coming months, and we'd love the opportunity to connect in person. These events bring together industry leaders to discuss the latest advancements in oncology drug development, and we look forward to continuing these important conversations. So you can find us at AACR in Chicago from April 25th to 30th at booth 3744. And we'll also be at ASCO in Chicago from May 30th to June 3rd at booth 32157. If you're planning to attend any of these conferences, we'd be happy to meet and discuss how Merit's independent central reading review services can support your trials. So feel free to stop by our booth or reach out to schedule a time to connect. So thank you for joining us today, and that concludes our presentation. We'll now open up the webinar for questions, so feel free to submit them through the QA box and we'll address as many as possible. I know we do have a few in there right now, so we'll start with the first question. So, Dr. Kim, this question has come in. I have an upcoming clinical trial where we are planning on using RANO 2.0. What clinical information should we capture from the EDC?
Thank you. Thank you very much, Chris, and thank you for the question, which is a very good question. So for the RANO 2.0, the clinical informations or clinical data vastly stays the same as RANO HGG or LGG. So the one important thing is actually the prior radiotherapy information. So chemoradiation, the most important date would be the end of the chemoradiation so that we can actually accurately assess that the first pseudoprogression window from that date. And then also ideally, if there are any either those contours or the area of the irradiated chemoradiation regions in the brain accurately described, that will actually help the radiologist to assess the target, non-target, what are the right classification of the lesion based upon that area, and what are the pseudo progression or non-true progression in terms of that irradiated area. So that's actually very important information that we would actually really collect at the baseline. So that's a important component to the clinical data. And then also on a baseline and a follow-up piece, a clinical status and also the corticosteroid dose change also has to be recorded and then also provided to the radiologist. So basically, clinical status that is not worsening because of the actual glioma or glioblastoma does not necessarily push the patient into the progression, but anything related to the disease progression, and that is reflected in the clinical status will reflect the overall time point of the progression. So that assessment outcome is something that is important to be collected in the EDC as well as into the imaging reading centers as well. And also a corticosteroid dose change from the baseline and on should be very important because that will actually also affect the assessment of the lesions as well as the outcome calculations. So any corticosteroid dates and also the type of the steroid, which would be always calculated back to dexamethasone equivalent doses. And then what are the changes? Are they increasing or decreasing or stable? That is another important component for the EDC as well as for the clinical data provided to the neuroradiologist in that case.
Thank you, Dr. Kim.
Thank you.
And then we have one more question in the chat that's come in. What type of MRI images are needed for a RANO assessment?
Thank you very much for another question here. So the RANO assessment will require the MR images, and it is very well specified in a brain imaging protocol recommendations in one of the publications, and that will include a T1 sequences of the pre, and also a T2 flare, as well as the post contrast injected a T1 contrast enhancement is also another important portion that needs to be assessed. So those are the main, and then there are other important couple sequences that is specified in that brain imaging protocol, which I can also follow with that link of the publications if someone really wants to review that, the whole publication. But I would say that is a very important, and also if the volumetry is also considered as a part of the exploratory type of the endpoint into the RANO assessment, then it is also important to acquire these T1 into the 3D acquisition mode per the recommendation of the imaging protocol for RANO.
So, thank you, Dr. Kim. And I think we do have time for one more question. So I'll ask the final question. How does backdating of progression work in the case of confirmation of PD? How does backdating and progression works in the case confirmation of PD is required?
Yeah, thank you, Chris. That's also a very good question. So in the case of the backdating, when the confirmation PD is needed or required in a reading workflow, the preliminary time point, which is confirmed by the confirmed PD in the next time point, very subsequent time point, the preliminary PD would be actually the date of the progression that needs to go backdated. But if the patient was determined to have a pseudoprogression instead of preliminary PD right after the confirmed PD scan, then the actual confirmed PD, the very first time point later after the stable disease can be the date of the progression in that case. So for instance, which should be a little different from the RECIST or the other criteria is that any new lesion appearance doesn't has to go all the way back to that date of the first new lesion appearance, but it's rather that any new measurable lesions has appeared and then preliminary PD has been triggered based upon a total SPD. And then if the lesion has been confirmed right after that preliminary PD, that would be the where you would just go right back into the preliminary PD. So thank you for that question. Yeah.
Thank you, Dr. Kim. I think that concludes all the questions that we have, but we all appreciate you joining us today on our RANO 2.0 webinar. And please look forward to our next webinars. We'll continue to bring them to you. And we look forward to meeting you all at AACR, ASCO, and future shows that Merit will be participating in.
Thank you very much for everybody.